Welcome to this educational activity in which Dr. Gary Condon from Drexel University College of Medicine and Allegheny General Hospital offers insights on evidence-based strategies to optimize the management of individual patients with glaucoma. The following audio is part of a certified educational activity, an expert story of a glaucoma patient's journey from diagnosis to treatment, applying the latest advances. Access the entire activity and complete the post-test at www.peerview.com/CRM. Downloadable slides and practice aids are also available.
Hi, I'm Gary Condon, and today I'd like to talk to you about glaucoma, the challenges in diagnosis, therapeutic options, and most importantly, strategies to help improve patient satisfaction, compliance, and adherence with therapy. Glaucoma is really a group of diseases that have one common final endpoint, and that endpoint is the damage to the optic nerve. And this is both functional and structural in the sense that these patients develop nerve fiber layer damage, optic disc excavation and cupping, if you will, and corresponding to that, associated visual field loss. And if untreated and advanced, can have a major impact on a patient's ability to function visually throughout their life. One of the biggest dilemmas in taking care of patients with glaucoma is the fact that they are generally asymptomatic. In fact, it's only when there's really severe visual loss that these patients notice that they have a particular disease. And that really is the biggest problem in identifying patients who have glaucoma and need treatment. There are many different types of glaucoma. Categories include open-angle glaucoma, where the anterior chamber angle is anatomically open, and closed-angle glaucoma, where there's clearly apposition between the iris and the trabecular meshwork. The major issue we deal with in our clinical practice day to day is in fact primary open-angle glaucoma. And this is the condition where there's nerve damage with no discernible reason or cause for that particular damage. Now, intraocular pressure is a term that's often mentioned when we talk about glaucoma, and that can be due to its strong association with the condition historically. And it really is the only element of the disease that we can actually treat or target for treatment, so to speak. Yet, elevated intraocular pressure is not necessary for the definition of diagnosis, and it is not necessary to see elevated intraocular pressure in patients for a diagnosis of glaucoma. This is a highly complex and somewhat confusing area in considering this particular disease. What is high intraocular pressure? Historically, we think of high intraocular pressures that are greater than 21 millimeters of mercury. And as I've said, these are not universally present at all in patients with open-angle glaucoma. So in fact, if we look at what percentage of patients actually have elevated intraocular pressure with the diagnosis of glaucoma, depending on what populations we look at, we can see as many as 30 to 80% of the patients as having intraocular pressures less than 21, and commonly in the mid to upper teens. Now conversely, elevated intraocular pressure can often be present without glaucoma damage. And this is a scenario we term ocular hypertension. So we can see ocular hypertension, or elevated intraocular pressure, if you will, existing in patients without open-angle glaucoma who may never develop open-angle glaucoma. And this is one of the things that creates a tremendous dilemma and confusion, if you will, as to who we should treat for glaucoma. So let's go to a patient that I've seen over the last several years, and this is Mary. Mary's a 48-year-old female. She's on no medical therapy and has a negative ocular history. And she's been followed for several years with intraocular pressures that range in both eyes between 24 and 28. Her corneal pachymetry, or corneal thickness, is listed here, which we're going to talk about in a moment. But what I'd like to bring your attention to here is that Mary's optic nerve head images that you see here look really pretty healthy. You will, however, notice that there's some optic nerve head asymmetry, with the optic nerve head on the left side of your screen being Mary's right eye, demonstrating a slightly larger cup, if you will, or perhaps some excavation of the optic nerve. So Mary represents what we would term a glaucoma suspect. She shows some of the features of glaucoma, but not the entire spectrum, so she does not yet have the disease. She may develop the disease. Intraocular pressure elevation, although considered a major risk factor, is not always a cause for glaucoma. And we term patients with elevated intraocular pressure to be ocular hypertensives. There are many studies that look and have looked at what factors could convert a glaucoma suspect into somebody who has full-blown glaucoma. One such study was the Ocular Hypertensive Treatment Trial. It was a 5-year randomized study looking at the effect of lowering intraocular pressure versus monitoring patients with elevated intraocular pressure. And these were patients with intraocular pressures between 24 and 32, half of them treated with pressure-lowering therapy, the other half monitored. And what the study found was in the patients that were left untreated, there was about a 10% likelihood that they went on to develop glaucoma. As opposed to that, the patients that were treated with intraocular pressure lowering had only about a 5% likelihood of going on to develop glaucoma. But most importantly, what this study did was it identified certain risk factors in this population that predispose them to the development of glaucoma. And these are older age, higher intraocular pressure, greater cup to disc ratio, thin corneal thickness, and a greater pattern deviation on their visual field test. And by that, it's a lumpier or less smooth visual field index, so to speak. Interestingly, family history is a relatively weak risk factor for the development of open-angle glaucoma unless a patient has a direct sibling or parent who's gone blind from the disease. So in view of these risk factors that have been identified, one of the things that have come to our aid in looking at these glaucoma suspect patients are things called glaucoma risk calculators, which essentially are online programs that you can plug your individual patient's risk factors into, and these devices will provide for you the likelihood that your glaucoma suspect would go on to develop glaucoma over the next 5 years. And these can be very helpful indeed. So who do we treat as a glaucoma suspect? Why is it important? It's important because it can have a major impact on that patient's life. They get labeled with a chronic disease if we decide to treat them. They're often burdened then with medical treatment ongoing for the rest of their life. So what we want to identify are patients that we think are worthy of treatment and those in whom we feel would be fine with ongoing monitoring. And this is a very challenging and gray area in looking at patients who are labeled as glaucoma suspects. We want to treat the high-risk patients. We want to avoid treating low-risk patients unnecessarily. So let's go back to Mary. We found Mary followed for several years with intraocular pressures between 24 and 28 and stable optic nerve head appearance over the years. In fact, this is Mary's right optic nerve, OCT on the right, and the associated visual field on the left side of the screen, both of which are quite normal. Over time, however, as we followed Mary, some years later, she arrived with an optic nerve head analysis here on an OCT image that in the top right portion of the screen you can see has dropped down to where she's demonstrating some thinning of the nerve fiber layer in that area. And that's the first time Mary has ever demonstrated a defect or nerve fiber layer change, if you will, in her examination. And this was indeed associated with a visual field defect in a very subtle way in the image you see on the right. So now what? Mary's whole picture has changed. Mary has developed a progressive change in both her nerve fiber layer and her visual field. And I would not consider Mary at this time to be a glaucoma suspect due to these changes. So we're going to treat Mary. And the question is, how are we going to treat Mary? We're going to treat Mary to lower intraocular pressure. We have to think about what level of intraocular pressure we're going to aim for. And the good news is, since we followed Mary for so many years, we have a good idea of her pre-existing intraocular pressure range. And that is of utmost importance when we embark on therapy, because we're going to aim for a new range of intraocular pressure. And to get where we want to be, we have to know where we started. So how do we treat intraocular pressure? What medications, what medication options do we have to lower intraocular pressure? Intraocular pressure is produced by aqueous formation, and there are really three mechanisms by which we can lower intraocular pressure. We can reduce the production of aqueous utilizing beta blockers, alpha agonists, and carbonic anhydrase inhibitors. We can enhance trabecular outflow historically with cholinergic drugs like pilocarpine, which have predominantly gone by the wayside due to their side effects. On the other hand, more recently, we have the most efficacious agents, which are the prostaglandins. And these work by enhancing uveoscleral outflow, the non-conventional mechanism of getting aqueous out of the eye. Prostaglandins can be used once daily. They have very few in the way of any systemic side effects typically. They're generally well tolerated and are typically now first-line therapy for intraocular pressure reduction in patients who have glaucoma or ocular hypertension. As I said, it's important to come up with a plan or a zone of target pressure range, if you will, for somebody like Mary. Now, we do have an intraocular pressure range that Mary started out in, and this diagram suggests that somebody like Mary, who has early disease without additional risk factors, who had a relatively high untreated intraocular pressure, would probably be fine with a reasonable mid-level of intraocular pressure. And in Mary's case, in discussing the options for therapy, the real advantage for the prostaglandin agents and why they're probably the number one first-line agent and why they are the number one first-line agent today is that they can be dosed once daily and that they do have the biggest effect on intraocular pressure for these patients. So Mary elected to go with the prostaglandin daily. Since then, her intraocular pressures have ranged between 16 and 19 in both eyes. This would represent about a 25% reduction in Mary's intraocular pressure, which is certainly reasonable. We like to see at least a 20%. We'll take 20%. If we can get 25, that's great. 30% reduction can be a bit of a home run. So ongoing monitoring for change is the plan with Mary. Her visual field, as you see on the right, now represents the new baseline that we'll be monitoring for further change going forward. We've engaged Mary into a plan for regular follow-up visits, and she's on board with this moving forward. Now, here's Joan. Let's look at Joan. Joan is a 62-year-old female who I first met in 2008, labeled as a glaucoma suspect with suspicious optic nerves, not elevated intraocular pressure, but suspicious optic nerves. She has a history of asthma. She's a myopic individual with good vision and untreated intraocular pressures in the mid to upper teens, say between 16 or so. She has slightly below average corneal pachymetry or corneal thickness, which might raise our level of risk concern for her, as we mentioned earlier. She has larger degrees of cupping than what you saw in Mary, and she has myopic peripapillary atrophy around these optic discs. So she has no elevation in intraocular pressure, she has low corneal thickness, she has atypical optic nerves, and she meets the category or label of glaucoma suspect based on these features. Joan, however, does on her visual field in her left eye demonstrate already superior visual field loss, and to a much lesser degree on the right. Now, over a period of between 2008 and 2011, we've been monitoring Joan with her intraocular pressures ranging between 15 and 18 in both eyes, and monitoring her structural aspect of her optic nerve, which is challenging because of the peripapillary atrophy I mentioned. And what we see here is in the bottom diagram on the screen that Joan is developing separation in the inferior zone of her nerve fiber layer. And this appears to be progressive. So what are we looking for at this particular point? Can we confirm that this is real change in Joan? Is Joan more than a glaucoma suspect? It certainly appears concerning. And in fact, despite intraocular pressures that remained in the teens through 2011, we discussed the situation with Joan, her optic nerve head, nerve fiber layer change and concern, and we elected to go ahead with intraocular pressure reduction based on the fact that she had the optic nerve or nerve fiber layer changes, she had the visual field deficit, and the apparent progression of the nerve fiber layer change. Joan does get a pressure response to the prostaglandin, and over the next few years we follow Joan as you see here. And Joan develops progressive superior visual field loss despite her intraocular pressures that are in the mid-teens on the prostaglandin. And it's clear that Joan has progressive disease despite single agent therapy. Joan needs a lower intraocular pressure. So we started out at 17, we started her on the prostaglandin agent, and she's now in the mid-teens, but through that time, evidence of progression. So Joan represents a much more challenging case when it comes to taking care of these patients with glaucoma. Joan is going to need more pressure reduction. It's clear to us. And I think that in reducing the risk of further progression in somebody like Joan, who's demonstrated the propensity for further visual field loss despite what we would consider remarkably reasonable intraocular pressures, we're going to aim for as low a pressure as possible in Joan using our conservative therapeutic agents. And by conservative agents, I mean medical therapy plus or minus laser therapy. So with Joan, we don't have the option of a topical beta blocker because she has asthma. What we do have is we have the option of a carbonic anhydrase inhibitor, which is something that reduces aqueous production. That would certainly complement her prostaglandin that enhances aqueous outflow. We have bromonidine, which can do a little bit of both. Or we could think about using both. And in today's medication environment, we have a fixed combination that includes both these agents. In the history of fixed combinations, prior to the fixed combination of bromonidine and a carbonic anhydrase inhibitor like brinzolamide, we only had fixed combinations that included a beta blocker and one of these two other agents. And clearly this would not be an option for Joan based on her history of asthma. The fixed combination of brinzolamide and bromonidine, I think, is a remarkably useful one. And this slide demonstrates that each of these individual components, represented by the blue and the red bars, applied by themselves have a nice positive intraocular pressure reduction. But if we put them both together in a fixed combination, as demonstrated in the green bars here, you can see that they have upwards of as much as about a 9 millimeter level of intraocular pressure reduction at peak and about 6 millimeter intraocular pressure reduction at trough. So these can be very powerful agents when added together. I mentioned the laser therapy option, and while selective laser trabeculoplasty or other forms of laser trabeculoplasty can be very helpful in patients with elevated intraocular pressure, when we consider somebody like Joan who has an intraocular pressure in the mid-teens, the likelihood that laser treatment would provide a major yield in pressure reduction is relatively low. So we're going to go with the fixed combination in Joan's case and essentially pull out all the stops with respect to medical therapy for her glaucoma. At the same time, the fixed combination not only proved efficacious in Joan's case, but it adds only another single bottle, if you will, to Joan's medical therapy. So this is Joan now, having been followed since 2012 up until 2016. Her intraocular pressures have ranged between 10 and 12 on both the prostaglandin agent as well as the fixed combination of brinzolamide and bromonidine. She's been compliant with her medications, which is a good thing. Her visual fields have remained stable throughout that time. In cases like Joan and all of these cases that we're concerned with, our biggest challenge, in my view today, in managing patients with glaucoma who are successful with pressure-lowering therapy with medication is having them stick to that therapeutic plan, having them adhere to their ongoing regimen of medications. There's lots of patient factors that affect their ability to continue with therapy: convenience, cost, obviously adverse side effects of the medications, all of which we take into consideration when we're putting patients on medication. The patient's belief, understanding about their condition, understanding what the impact might be if they just throw their drops aside and forget about it, because as I said, patients with mild or early glaucoma and even moderate glaucoma are relatively asymptomatic. And so they have no reason to feel the need to use their medication. In that regard, I think it's important to really engage with your patient, understand their limitations, be communicative with them, and listen to them. Ask very open-ended questions about how they're doing with their medications. Joan, how are you doing with those eye drops? Not Joan, I assume you're taking your eye drops. Joan, when did you take your last eye drop? Joan, how are you doing with your eye drops? Bill, I often use the term, Bill, what's your batting average with those eye drops? 500, 750? Just give me an idea. And tell me the truth. I'm not going to beat you over the head with a baseball bat because you can't remember to take your drops. That's just not going to solve the problem. I want to be on your side. I want to be on your team, and for that to happen, I need to know the reality of your day-to-day life and how you're managing with your medications. And we want to tailor our approach to patients. We want to obviously reduce the burden of medication as much as possible. Fixed combination agents have been able to help us with that tremendously. So educate our patients, again, with proper eye drop installation and whatnot, can be very helpful for enhancing adherence and compliance. So in summary, the therapeutic decisions we make, the diagnostic procedures we follow, the monitoring of the patients we follow are all very important. But if at the end of the day, we don't have the patient fully engaged and involved in their own treatment for glaucoma, we're going to lose, and they're really going to lose. So think about educating your patients more fully. Think about listening to them. Try and get the reality check. It's not always a lecture to the patient. It should never be that. It should always be a, you tell me what's going on in your life, Joan or Mary, and I'm going to help you try to make it better. And with that, I'd like to thank you for letting me discuss with you today some of these approaches and challenges in managing the patient with glaucoma.
This activity has been jointly provided by Medical Learning Institute Incorporated and PVI, Peerview Institute for Medical Education. Thank you for listening. Download materials and complete the post-test for instant credit at www.peerview.com/CRM. This activity is supported by an educational grant from Novartis Pharmaceuticals Corporation.